became secretary for somebody else, so I was sort of balancing lots of things, and I really didn't know what I wanted to do. When I did my body massage, I focused on the nervous system. And the reason I focused on the nervous system was because I had a son who had a condition called adrenal leukodystrophy. And adrenal leukodystrophy is a condition which is demyelinated, so it breaks down the myelin sheath around the nervous system. And when it does that, they can't do anything for themselves. So he couldn't swallow, he couldn't see, he couldn't walk. He was fed through a gastrostomy tube. So that was my first sort of pathway in to the nervous system. I had to write a dissertation as part of my massage certificate, and it came back as one of the best that they'd seen. And that's because it came from my heart, because he was my boy, and I wanted to fully understand what was going on with him and his condition. So that was like the interest, that sparked the interest. Then in 2002 he died, and I was completely lost. I didn't know what to do myself. I didn't know where to go, I didn't know who to speak to, and I thought, oh, okay, what should I do? And I thought I wanted to do nutritional medicine. So I signed up to the Glasgow College to do nutritional medicine. And I did about a year, and it really wasn't giving me that boost. And I thought, I don't know where to go now, I don't know what to do. And then the University of Portsmouth were putting on a degree course in natural and complementary medicine. And I thought, do you know what, all I've got is a level 3 qualification. I'd quite like to learn more so that I can help my students to learn more. So I'll go and do a degree. Well, when you leave school at 15 without the qualifications, it's a little bit difficult to get into university, and I couldn't. But the person that was running the course, she was the senior chemistry lecturer, and she invited me along to go and have a chat with her. She'd done trained in aromatherapy at Fareham College, where I'd been a teacher, and she didn't like it. She liked the chemistry side of it, but she actually didn't like having the treatment. She didn't mind giving it, but didn't want anybody to touch her. So her background was actually electrochemistry. So it seemed a bit of an odd connection for somebody who teaches chemistry wanting to do something in natural and complementary medicine. That came about because they didn't have enough students coming in to learn chemistry at university. So they said, you need to think of something else. They developed the course, and I went to see her, and she said, would you like to lecture on it? And I said, no, I want to learn it. So she said, well, we haven't been validated yet, so we just need to make sure we can get the course validated. So they put it before the education boards, and they declined. Said, no, it's not got enough in it, you need to rewrite it. So they rewrote it as biomedical sciences and natural and complementary medicine. And again, they asked me would I teach on it, and I said, no, I wanted to learn. I wanted to understand the science behind it all. So she said to me, would you like to do a master's degree? And I said, but I don't have a degree. So she said, well, if you go away and do an access course, with your background and the knowledge that you already have, you can come in and do the course. So by the time we'd had this second conversation, it got revalidated. The chemistry course at my local college had already started. So I think I joined it in the February, and I had to complete it by the July. So I did, and I got an A star in chemistry, and I'd never done any chemistry before in my life. I couldn't understand why I needed it. So I went in to see her, and she said to me, "Have you ever thought about this master's degree?" I said, "Well, I don't know what it is. I hadn't been to university, so I didn't understand all the processes and everything." She said, "Oh, it's research. What would you do research in?" And at the time, I was getting a lot of results from Reiki with my clients in terms of their pain. "Oh, no, no, no," she said, "we can't do that." She said, "You need a physicist for that." She said, "I'm an electrochemist." She said, "We can't do that." She said, "I don't have the personnel to do it." "What else?" So I said, "Well, I have a huge elderly client base who have a lot of arthritis, and I'm getting really good results with reflexology and arthritis." "That sounds better," she said. "I know someone who can help with that." So I go, "Okay, fine." Anyway, I went to register and everything, and she said to me, "It will be a master's," but she said it's it will lead to a Doctor of Philosophy. And she said, "We'll pay for the first 3 years." And I thought, what's going on? Right place, right time, that kind of thing. How come I'm here? Anyway, it was all sort of falling into place for me. They were going to pay, they were going to teach me, and I was just going to have to attend. So I thought, okay. So I thought, right, okay, this is the universe telling me this is where you're meant to be. So I thought, yeah, I'll get along with that. Went along with it. Went in, and they said it would be 3 years full time and they'd pay. And I said, "Well, I can't do full time because I need to earn a living." And I was working at a GP practice at the time as receptionist and secretary to the GPs. So she said, "Okay, well, it would be 6 years part time." I said, "Fine, sorted." So then she phoned up registry, and registry said, it has to be a structured research program. So I said, okay. So we talked about what I would do, and I said about the pain stuff. So she said, okay, we have a neuropharmacologist who's done some work on transcutaneous electrical nerve stimulation and acupuncture, and got good results from that. So he will make a good supervisor for you. So I met him, and I thought he was a bit weird. He was very quiet, very soft voice, and you would ask a question, and he would go off on one. Has he answered my question or not? And that pattern was to follow all the way through my time with him at university. I'd go and ask one question, and I'd still be there 3 hours later, and come out at the end of it and think, did he actually answer my question? And it was difficult. Anyway, one of the first things I had to learn was neuroanatomy and physiology. I thought I knew it. I thought I'd done it in my level 3 diploma, and I understood the nervous system. Not a chance. No, I hadn't even scratched the surface. So it was a deep, deep dive into neuroanatomy and physiology. Then it was the endocrine system. Then it was research skills. And at the same time, doing a literature review. What's already been done on reflexology? How have you got there? Has anybody done anything on what you want to do? And I didn't even know where to begin. Well, how do I find that out? Well, you have to look at the literature. What literature? Where? And they say, well, there's a search engine. Okay, I'm not that computer literate, I'm not stupid, but what do I put in? What are the terms I need to put in? So they sort of told me this is what you need to put in, this is where it needs to go, etc., etc. And I started to put in these terms, and I was coming up with thousands of paper, just loads and loads and loads, not all related to reflexology, but I had to understand pain first. I had to understand neuroanatomy, I had to understand the brain, I had to understand the pain pathways, how different neurochemicals affect different things and everything else. And my head was just exploding with so much information. But I kept going on it, did the literature review, and then they said I needed to do a research methods training. What they did was put me into a lab-based research methods training, not a health-based research methods training. So my research methods didn't relate to what I was doing. It was for those that were doing the lab work. Nobody said anything. I didn't know that that wasn't the right one for me. I didn't know where I was supposed to be. I just thought they were telling me the right things and I went along with it. As time went on, it became more and more stressful, more and more challenging to try and understand what they were saying to me. And I think we got 2 years in, and I'd done the basics with the neuroanatomy, I'd done the basics with the endocrine system, and the research skills. That was fine. Thought that I'd had enough there. And they said, well, now, we need to get the experiments off the ground. What are you going to do? And I'm thinking, why aren't you telling me what I need to do? You need to devise your own experiments, and then you need to devise a hypothesis. What is it you're looking to find out in reflexology and pain? So the answer to that was I wanted to see whether or not reflexology attenuated pain. So we were thinking about chronic pain. But of course, if you've got people who are in chronic pain and are on lots of medication, you can't tell them not to stop. You can't tell them to stop their medication. So that then adds another complex factor to your research, because you have to account for what's going on with their medication, how much of it is their medication and how much of it is what reflexology is doing. So we thought, okay, let's put chronic pain on the back burner for now, and let's start with acute pain. Okay, so let's start with acute pain. What are we going to do with acute pain? There are lots of different ways you can inflict acute pain on people. And the one that we selected was the ice pain method. So ice pain is one of those things that they use to look at cardiac patients, because it tells them a lot about what's going on with the sympathetic nervous system. So what they did, or what they had to do, was plunge their non-dominant hand into a bucket of crushed ice, which was minus 0.5 degrees. They put their hand up to the first wrist crease into that bucket of ice, and they kept it in there until they got the first sensation of pain. That first sensation of pain is considered your pain threshold level. And we all have a very similar pain threshold level. So we will all start to feel the pain from heat at 46 degrees. Our pain tolerance level, on the other hand, is completely different. And that's a lot to do with the type of person that you are, the amount of pain that you've had across your lifetime, and how you manage things generally. So your pain tolerance level is how long you can withstand that pain. So the first signal was pain threshold. Keep your hand in the ice until you can't stand it any longer, and then you say out. And that's the pain tolerance level. Okay, so they're the two measurements. Pain threshold, when they first get that sensation of pain, that was my first measurement, and then pain tolerance for how long they could withstand it. And what we did was we did a baseline reading, first of all. So before any kind of treatment, how were they managing it? And then I did a 45-minute reflexology session, just a normal all systems reflexology, not targeting any specific areas, just a generalised treatment with my standard pressure in the reflexology. And then we measured immediately after their treatment, and then they had to plunge their hand in ice again every 30 minutes for 2 hours after the end of the treatment, where we took their pain threshold and their pain tolerance level. Now that's pretty uncomfortable for anybody. So the biggest single problem I had was recruiting them. I wasn't paying them. I just said, would you please come along and participate in this research? And I could only use people within the university as well. So I created charts and sheets, pasted them across the different divisions of the university, and said, come and have a relaxing time with me in the chair. So what we couldn't do, I couldn't talk to them whilst they were doing it. I couldn't play background music while they were doing it. I couldn't tell them what was happening or what I was doing. They literally had to lay in the chair, plunge their hand there. I'd strapped them with a heart rate monitor as well, because I wanted to know what was going on with their heart. Plunge their hand in the ice every 30 minutes and then read a book in between. And then get up and do it again every 30 minutes throughout the 3-hour period. I'm just going to backtrack on that a minute. So before we did the ice pane, what we wanted to know whether or not reflexology on its own changed physiology. Does it have an impact on heart rate? Does it have an impact on blood pressure? Does it have an impact on temperature? So we did it without ice, just to see whether or not people were going to get stressed beforehand. And it showed that there was an impact. I'll check on my results here because it's such a long time ago. So I don't think you can see that. That's somebody with their hand in a bucket of crushed ice there that they had to do. So, so looking at the physiology, I recruited 14 people and I did standard reflexology on changes in basal physiological parameters. Blood pressure, heart rate and core body temperature. They had just 30 minutes of standard reflexology and then 30 minutes of sham transcutaneous electrical nerve stimulation. So for those of you that don't know what transcutaneous electrical nerve stimulation does, is you put pads parallel to the site of pain and it interrupts the pain signal to the brain. So it acts like a gate, stopping that signal getting to the brain. And you just get like a fizzy feeling here. Now I had to tell people that they were getting a TENS treatment and comparing that to a standard reflexology treatment. So what I had was a machine, okay, this little machine, and all it was a digitized running meter. And at the back of this machine, I put a couple of crocodile clips which I attached to some TENS pads, and I put on their opposite arm, or their opposite forearm. And then I would say to them, tweaking the knobs, tell me when it starts to feel, you start to feel it. And if it gets too strong, let me know and I'll turn it down. Okay? That's all I did was tell them. There was no current coming through this sham TENS, nothing. But I made them think that there was something there. People said, oh yeah, I can feel that. Can you tell? There was nothing there. It was placebo. It was what was up here. Right? So we did that with the first experiment and then with all subsequent experiments because we don't know whether it's our touch, whether it's our interaction with the client that's making a difference, or whether it's just holding space for them. And they're non-specific elements of reflexology that you can't account for in research. So you have to think as many different ways as you can to try and exclude those. So I wasn't allowed to talk to them. I only touched them for the purposes of doing reflexology. And yes, there was a placebo, which was the sham TENS. And we know that it acts as a placebo. And 45% of people respond to placebo in terms of pain management. If you tell them that something will work for them, then it will. That's a huge figure, but it is a fact. So what did we find after this 30 minutes? The 1 week they had reflexology, and then we didn't know what the washout period was going to be. So is reflexology cumulative? You know, if I give it the next day, will that have an impact on the result the day before, or should I leave it? And Peter's work, Peter McCarrick's work, I looked at their research and they said there was some carryover effect. So we decided to leave a week between each session. We gave them a week. And then so 1 week they had the reflexology, and the next week they had sham TENS. And these were reflexology naive people. They'd never had a treatment before, so they didn't know what I was doing, not really. And the results of the physiological said that there was a significant decrease in heart rate during and after standard reflexology. So then the next one I had to do was standard reflexology in the ice pen experiment, which I've already explained to you. So what was the results of that? So they had 45 minutes of standard reflexology and 45 minutes of sham TENS. And I only had 15 people in this one. Again, it was given 1 week apart. There was, again, that significant decrease in heart rate. So we can, as I've heard you say earlier on, we can actually say it is very relaxing, it helps to decrease stress. Now, stress is a major factor in the pain profile, because stress increases the release of cortisol into the blood, which increases the inflammation. So the more stressed you are about your pain, the more likely it is to be uncomfortable for you. So we're just by giving a standard reflexology session and helping to relax, you're actually lowering that inflammatory response, because they're de-stressing during that time. So even that itself makes a difference. So significant decrease in heart rate before and after the ice immersion. Now, if you know that you've got to plunge your hand in the ice, first time you do it, you don't expect. When you know you've got to do it every 30 minutes for 2 hours after treatment, that's going to get you a bit anxious, isn't it? And you'd expect the sympathetic nervous system to start running away with itself. But actually, after the reflexology, the first 60 minutes, or the first two plunges after reflexology, their heart rate was still lower. So they weren't getting stressed, or if they were, reflexology had significantly impacted it, that it kept their heart rate low, which was quite interesting. So we also found that there was a significant increase in pain threshold for anyone that had the reflexology, and a significant increase in pain tolerance at the 60-minute time point and also the 90-minute time point after the end of their reflexology, when compared to the sham TENS control. But that wasn't enough. Because we knew that TENS acts as a placebo, we had to introduce another element. So we decided to introduce a no treatment. So you just come and sit in my chair for and relax, but you still got to plunge your hand in ice. So we did one. What I also wanted to look at was whether or not the amount of pressure that I applied made any difference. So I did a light reflexology. I did my standard pressure, and we did a no treatment at all. So again, recruiting for something like that, when they know they've got to plunge their hand in the ice, and I had to double the number of people to get the statistical significance. So I had to recruit a minimum of 30 people to get the right confidence interval for people to say, actually, yes, it's the treatment that's having an effect and nothing else. So I recruited 30 people for it, and we did. And what did it show? It showed that there was a significant increase in pain threshold for both standard and light reflexology. So your pain threshold, doesn't matter what pressure you apply, you're still going to impact their pain threshold levels, that first sensation of pain. What it showed also was that there was a significant increase in pain tolerance for standard but not light reflexology for pain tolerance. So standard reflexology is better, not a light treatment. Standard reflexology is better for anybody that wants to reduce or improve their pain tolerance levels. What does that mean? It means that with the help of their general practitioner, their consultant, or whoever is prescribing their medication, they may be able to reduce the amount of pain-relieving medication that they take. And if you can reduce the amount of pain-relieving medication that you take, you have a better quality of life. You can become more mobile. And when you become more mobile, a lot of those pain signals disappear. You know, gone are the days when somebody had said they had a slipped disc. You don't actually slip a disc, but when somebody said they had a slipped disc, you'd lay on the floor for 2 weeks and do nothing. That's not what we say now. We tell people to move, but do it in stages. So you build up a program for people with their pain. And with the advice of their GP, they can say, I want to be able to come off this. Can you help me titrate the medication down so that I'm coming off it in a sensible way? You know, you're not just saying to them, if they're on cocodamol or codeine or something like that, just stop it, it's fine. No, it's not fine. There are all sorts of consequences for something like that. So it must be done with their GP. And also to get them mobile. Do that in stages. So we're looking at, so I had an 82-year-old lady who had a fall and she didn't want to move. So we did it, she had a frame and I got her moving from her chair to the table, just on that. And then over a number of weeks she'd move a little bit further and then so you do it in a process, in a gentle process so that they can move gently. Her aim was to drive again. It took her 18 months, but she did do it. So always do it slowly. There was again that decrease in heart rate for light reflexology and standard reflexology before the ice plunge, before they plunged their hand in the ice plunge. After the ice plunge, it was only there for the light reflexology. So your light touch reflexology is having a greater effect on your sympathetic nervous system and introducing more parasympathetic activity, which you would expect. So the light touch is better just to bring everything down and keep people calm. What we also found that there were biphasic responses. What do I mean by that? So there's something called a nociceptive effect. A nocia means to harm, and an anti-nociceptive effect. So the opposite to that. And we had both coming up. So some people found it more painful than others. And it came in at different stages, so that really complicated all my results, and people didn't know what to do with that. So that was important. The other thing to say is that there is no one size fits all. What I also found in my research is that there are a lot of responders, but there are equally as many non-responders to reflexology. It's a bit like going to your GP and getting some medication. It works for you, but actually it doesn't work for you. And that's you as an individual. And that's why every single person who's sitting in front of you, you're doing an individualised treatment plan. Because no one size fits all. Find out about that person, what's going on with them. You know, in terms of pain, it's not just about I've got backache. What's going on socially for you? What's going on within the home? You know, what's going on financially? And as we said before, you know, people offload when they're in your chair or bed or whatever it is where you're doing your treatments. And they do it without thinking. They want to talk to you. They want you to know things. So you need to know all of those things. Because when you get all of that, then you can help them more. Because pain is multidimensional. It's not just the physical aspect of it. There's a huge amount of psychology and emotion stuff going on with people in pain. So that's really important. I think I got to experiment 3, and then I was having lots of problems in my relationships with my daughter, with my husband, because I was always at university. Because people weren't necessarily able to come during the day. So I gave up my job and decided to dedicate full time to university. But it meant I was there sometimes till 10 o'clock at night, just trying to get everybody in, to fit in. You know, you think you've got 30 people, they've got to come once a week for 3 weeks for 3 hours. That's a heck of a number of hours. So I wasn't there when my husband needed me. I wasn't there when my daughter needed me. It's a very selfish thing to do. But I didn't feel I could back out of it by then. You know, I was so far in, I felt I had to do it. At the same time, I had my director of studies, the electrochemist, so she's the chief person that manages me, and my supervisor, the neuropharmacologist, telling me I didn't have enough up here. I couldn't do it. You know, you'll never stand up to a advisor. You don't know what you're doing next. All the way through, they were telling me I couldn't and I shouldn't. In 2004, my husband and I went on holiday at Christmas to Sri Lanka. And we got caught up in the tsunami there. And I was crushed under a pipe that crushed my lower leg. I was the only person in the hotel that was injured. My husband had gone, we were in a cabana, and my husband had gone to the cabana to try and get me some clothes because they wanted to take me to hospital. We didn't know what was happening island-wide. We thought it was just our little bit. And when he disappeared, another wave came. So I didn't know where he was either. He came back, he was covered in cuts and bruises all over the place. We had 2 days before we came home. We both had post-traumatic stress, as you would expect when we got home. But what struck me when I was out in Sri Lanka is that all these people were hurt, all these people were injured. And for all my knowledge with reflexology and pain, I didn't have the medical background to help them. And I thought to myself, why am I wasting my time on a PhD with people who tell me I can't, I won't, I shouldn't, when I could be doing something better? So when I got back, I thought, okay, I'm going to give this up and I'm going to go and do nursing. So I went to Southampton University, and Southampton University said, yes, we'll take you. You can do nursing. We'll gladly take you. I thought, okay, fine. And then one evening, I sat and meditated, and I was clearly told, no, that's not your path. You are where you are meant to be, right here, right now. So I then went back to my supervisors and my director of studies, and they said, no, you can't, because we're not going to fund you anymore, because we don't think you can do it. You can leave now with a DPhil, which is, it's a good qualification to get, but it's not a PhD. I thought, no, I'm not doing this. You're wrong. I am where I'm meant to be. I just wholeheartedly believed that was my path. That's where I had to be. So I went to registry and I complained that they weren't supporting me. And obviously that didn't go down well with my supervisors, and I just felt everything shift. And it was a fight not only at home, but also in university. And they gave me 12 weeks to rewrite what I was doing and come up with more experiments. They said you won't get enough people for a full PhD, you won't be able to write the thesis. Just everything was negative about it. And I was getting more and more stressed, I got more and more pain, so I already had arthritis before I went in. It got much worse. I got on 3 stone in weight because I was eating carbs like you do when you're stressed, you know, all the wrong kind of foods and everything. And I had to find money to pay for it. And I did. I paid for the restaurant. I said, no, I'm staying. Here's what I'm going to do. And I presented them with it. And they said, okay, you need to write this. So I wrote what they asked me to do. And then they said, yeah, okay, we'll see how you go. One of the things that they wanted to do was measure pressure. Nobody's ever done that with reflexology before. So I said earlier on I did an experiment which was light and standard. But my standard might not be the same as yours. My light might not be the same as yours, but I had to measure what was the difference between my light pressure and my standard pressure. So we got some equipment over from America, from a company called Tactilus Freeform, where they were looking at plantar pressure whilst walking. So they put these pads down on the floor, people would walk over them and they'd know how much pressure. Then there was something that came up on cobblestone mat walking, and that in Asia, if you walk on cobblestones, you're stimulating the reflexes in your feet, and it has an impact on your blood pressure. And they proved that it was having an impact on blood pressure. So we got the equipment from the States, and the sensors that they gave me kept breaking. So we sent it back, they remade them, and I measured again. So I measured my light pressure, light dynamic, so thumb walking, standard dynamic, and a holding pressure, as in nerve reflexology. Now I'm a UK tutor for nerve reflexology. Nerve reflexology is a static holding pressure. It's very, very precise kind of treatment, and it's extremely accurate. Right? So we tested that. We tested it on the heel because the heel has the biggest fat pad. We tested it on the bony projections of the spine. We tested it on the soft tissue of the abdominal area, so your digestive system, your organ system, and we tested it around the malleolus. And we found that there was changes in the pressure, so where am I with that? So that was 4 different regions. Data showed variations in average maximum pressure values according to the foot type and area treated. Basically, what we're saying is that for every different foot that you treat, you use a different pressure. So I had a baby who was 18 months old, and my oldest was 83. I had feet that were flat, I had feet that were sweaty, and all of those made a difference to the contact area that you were getting with the pressure when you were doing reflexology. So it was a really fascinating piece of research to do, and I'd like to do a lot more on that, but that's not where my things are going. I also looked at mechanical reflexology. So is the practitioner important? Is it the touch? Is the practitioner important in terms of reflexology? Or does the machine do the same job? And again, it was hard to recruit for that, but the results for mechanical, so it was just, so you can't see it very clearly, but it's like a foot massager, you know, where you put your feet on and it vibrates under, like a plate underneath, so it stimulates the points underneath. You were 12 people, they had 20 minutes of mechanical reflexology, 20 minutes of Chantaines. Again, pain threshold, tolerance and heart rate. No significant effect of mechanical reflexology when compared to Chantaines. Transient benefits of mechanical reflexology on pain threshold during the stimulation, not after, like it was with normal reflexology. And transient benefits on pain tolerance after the stimulation. So that's saying that there is an impact whether or not you're there, but more work needed to be done on that. Again, was there a cumulative effect? So that was another experiment that I had to do. And by this time, people have had enough of me. You don't want to come. So I had to recruit those that I'd already had before. So they knew what they were getting before we did it. And I had 11 women, no men. No, the men wouldn't come. I had a couple of men who came once and then decided they wouldn't come again. I had one man who came whose pain thresholds levels was over 300 seconds, and I wasn't allowed to let them plunge their hand into the ice for longer than 5 minutes. So I had to say, no, I can't use you. I found out later on he was an alcoholic, and he'd been drinking. He'd been drinking before he came to me, so that was why his levels were there. He was a bit numb and everything. Pain threshold and tolerance again, and also blood pressure and heart rate. Repeated reflexology treatments produce a trend towards an increase in both pain threshold and pain tolerance. So over a period of time, yes, you are helping, and the treatments are cumulative in that respect, but they are not cumulative in terms of helping to lower blood pressure. So there was no impact, and I'm not the only person that's looked at blood pressure and not seen a response. We know that it works through the circulatory system, but actually doesn't change blood pressure. And a lot of that might be lifestyle factors, rather than, oh, I'll twiddle with your feet and everything will be okay. It doesn't work like that, it's not that simple. So,
But the accumulative effect was on pain. The accumulative effect was on pain.
Pain threshold tolerance,
Yeah,
yes.
thresholds.
So, by now, I'm 7 years in. I'd gone over my time, and they kept telling me, you've got to finish. And I'm trying to write my thesis at the same time. My thesis kept coming back to me. You need to write as an academic. Stop the touchy-feely stuff. This is science. Put the evidence in, put the papers in where you have found that evidence, judge that evidence, and include it in your text. It was a whole new way of writing. I'd never written anything like that before, so it kept on coming back time and time and time again. It did eventually get done, and on the 12th of January 2010, I had my viva. So I have to go in front of a board of people. One was an external examiner from Westminster University, one was our head of school, who was my internal examiner, and my supervisor, who was a neuropharmacologist, didn't want to come in. So I had my electrochemist who knew nothing. She didn't understand what I was doing in terms of that. She would always refer me to Ida, who was a neuropharmacologist. Anyway, she came in. And when you're first in, they try and make you feel comfortable. So they ask you a question, tell me about the divisions of the nervous system. I went completely blank. I was so nervous I couldn't speak. I couldn't let the words out. So they rephrased it. When they rephrased it, I could then speak. And then they asked me the question, why did you do this, 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 and this? You have to defend it, basically. Why did you do it? What were you trying to find out? Da 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 da. How has that impacted, etc. Did it. Then you wait for somebody to come out and say, you've passed or you've not passed. So they came out and she said to me, you've passed, but there are corrections. So, okay. She said, we're going to give you a year to write those corrections. I'm 8 years in. I'm 8 years in already, okay? So I went to her office and she said to me, Carol, she said, I have to say, she said, I've been teaching for more than 34 years. She said, and you are the most tenacious student I've ever met. Hence the name of after that was, I didn't see her for a while. I had to wait until they gave me a list of all those corrections that I needed to do. Most of them were statistics, and statistics was my worst nightmare. I still struggle to get my head around statistics. And if I changed the statistics and did what they do, it meant I had to rewrite loads of stuff because it changed the results. So in March, I went looking for Sheila, my director of studies, and I couldn't find her anywhere. And somebody had said to me she'd been ill. And I eventually found out that she was in hospital. She had acute myeloid leukemia. So that was the March. And then in June, I went for a mammogram, and I was told I had breast cancer. So, as far as I'm concerned, it was stress. That's what brought it on for me. It changed my internal environment, but it wasn't just, stress is good, it can be good, but if it's ongoing, it can kill you. So, they told me I had breast cancer, I needed surgery, I needed chemotherapy, I needed radiotherapy. The day I went in for my surgery, I had a little tiny sip of water. So they took me to the bottom of the list and said, no, you can't have it yet, go away. So I went to find Sheila, and her treatment hadn't worked. She wasn't going to survive. She knew she wasn't going to survive, and she was never going to meet her first grandson. So we had a heart-to-heart. Even after all that we'd been through together, we had a heart-to-heart. She said, why are you here? And I told her I've got cancer as well. So she said, you'll come through. And I went and had my treatment, and in the August she died. And I was writing my corrections, and I needed to work as well. So I applied for a post at the University of Surrey in cancer research. I'm never going to get it, but I want a postdoc, I need to work. I needed to take my head out of me and go and see. The day I went up for my interview, I had my first chemotherapy session in the morning. I drove to Surrey, and my hand was all bruised. And she said to me, why is your hand bruised? I said, well, I've got to tell you, I've got cancer and I'm going through treatments. And I thought, they're never going to give me a job. Not only had I not done any research in cancer before, but I was going through cancer myself. I got home, 5 o'clock that evening, I got a telephone call, would like to offer you the job. So I did my postdoc research in cancer. And since then, I've been doing some research for pain in cancer survivors. I teach a course, Pain in Cancer Survivors, and next month, after 5 years, I'm going to present it to the Research Council for Complementary Medicine, showing that reflexology has a beneficial impact. In a pilot study, it's got a long way to go, but in a pilot study, has a beneficial impact for people with chemotherapy-induced peripheral neuropathy. So that was my journey.